Moving towards our third scientific session, and the topic is women with hirsutism may have PCOS and other hormonal dysfunction, including glucose intolerance, hypertension, and obesity. To discuss on metabolic implication or hirsutism, we have our next most energetic speaker with us, Dr. Satyam Chakraborty, consultant endocrinologist, Fortis Group of Hospital, and he has associated with HDS since long. And to chair this session, I would like to invite Dr. Kaushik Munshi, internal medicine consultant attached with VKR Nursing Home, Uttarpara. Sir, I would like to request Chairperson to please come over the stage and introduce our speaker. Okay, we have another Chairperson with us, Dr. Satyajit Roy, HOD, Department of Medicine, Central Hospital, ECL. I'd like to request Dr. Satyajit Roy, if you were present in this hall, to please take your seat and introduce our speaker.
Hello. Good morning, respected delegates. Now, without delay, I will call Dr. Satyam Chakraborty, who is an eminent endocrinologist and a brilliant speaker as an honorary faculty, the Division of the Reproductive Physiology, Department of Physiology, Kolkata University, and the reviewer of the Indian Journal of Endocrinology and Metabolism, more than 16 publications. I will request Dr. Chakraborty to start the session.
Good morning, everybody. I see few of my teachers also there. Dr. Arupratam Datta sir was there, Dr. Pundit was there. So I start my presentation with a young patient. And she's a 19-year-old female, born of consanguineous marriage, presents to the clinic for an endocrine referral. And you all know why she was referred. You can see the chief complaint of excessive hair growth and oligomenorrhea. And parents explain that the hair growth was insidious in onset, and was become noticeable from around 12 years of her age. So when the FG scoring, which is the basis of clinical examination as far as any case of hirsutism is concerned, we had a score of 28 in this female. And I asked for the hormonal workup, and the 17 OHP was quite high. So was the androstenedione levels. Even the 8-am serum testosterone was high. Serum prolactin, TSH, Diaz I did not do. And the patient was euglycemic. So what I am trying to show is the usual laboratory workups to approach a hirsute female are listed. Now we explained that the parents complained that it was of an insidious onset. So I did not go for the Diaz level, because Diaz level basically are for to find out, to exclude neoplastic etiology in abrupt onset hirsutisms. So I refrained from that, and patient was euglycemic. So these are the usual hormonal workup. Now, these hormonal workups are preferably performed in day 2 to day 4 of the cycle. But if the patient is amenorrheic for more than 2 months, we can always perform these workups randomly. So moving ahead, hirsutism is such a vast topic, and there are a lot of aspects which we can discuss, starting from definitions, the etiology, the pathogenesis, and finally the management, and overall how to approach a case of hirsutism. But today the organizers have given me the responsibility to discuss the metabolic implications of hirsutism, although I will not restrict myself totally to the metabolic implications, but our main discussion will hover around metabolic implications. So I start with this slide that obesity, it is actually a pro-inflammatory milieu, and with the breakdown of the adipocytes, they invite a lot of inflammatory cytokines which create an inflammatory milieu, thus resulting in a atherosclerotic pathophysiology in the body of a human being. And by this age-old illustration, we find how much obesity is important as far as the metabolic outcomes of stroke, ischemic heart disease, and deaths are concerned. Now, approach to hirsutism, we should have an overview of what are the common causes. Now, the most common causes of hirsutism which we deal in our day-to-day life are the PCOD groups, the congenital adrenal hyperplasia group, the functional group, the familial variants, and the idiopathics. But we need to understand that there are some other reasons also, endocrine reasons, which might be important. Now, we need to understand the basic reasons. Any endocrinological condition which will increase the free testosterone level, which will decrease the serum hormone binding globulin, thus increasing the free testosterone, which will increase the DHEA level. For example, hyperprolactinemia, they directly increase the DHEA's level. So that causes the hirsutism as far as hyperprolactinemia is concerned. So hypothyroidism is also there. Now, if you talk of PCOD, the specificity spillover of insulin to the LH receptors. This is one of the reasons. A young female patient who is hypertensive with a normal BMI with hirsutism, we need to think about glucocorticoid resistance. So these are the areas where we should keep in the back of our mind when we are dealing with any case of hirsutism. So what is the problem statement as far as today's topic is concerned? Either low or high testosterone levels have an increased risk of cardiovascular disease independent of age, adiposity, ovarian function, and smoking. The prevalence of obesity in non-classical congenital adrenal hyperplasia and congenital adrenal hyperplasia exceeds 35%. That was the reason why I showed the obesity and inflammation slide at the outset, which is well above the general population trends. 1/3 of untreated NCCAA children have insulin resistance. CAA children have high levels of leptins and other adipokines which predispose them not only to visceral obesity but also altered feeding pattern. They are hyperphagic without them even knowing, which ultimately increases the risk of adverse cardiovascular events. And finally, what is the usual treatment of this congenital adrenal hyperplasia? The salt wasting variety, the partial variety, and the severe NCCH, we use glucocorticoids. Now we need to understand that glucocorticoid use in high doses for the purpose of androgen suppression could induce Cushing syndrome characteristics and further aggravate the existing cardiovascular risk factors. Not only the cardiovascular risk factors, as far as endocrine metabolism is concerned, we are forgetting that bone is also an endocrine organ. And here, over-aggressive use of corticosteroids will cause unopposed osteoporosis. So that also we should keep in our mind. That's why if you see the latest guidelines, in the non-classical cases, they don't recommend the use of glucocorticoids, or if, like our index case, where there is severe hirsutism, I was personally forced to use glucocorticoids, but when I am using, I make it sure that I use it in the lowest dose possible, if possible in alternate day regimens, along with anti-androgenic OCPs, and if required mineralocorticoid receptor antagonist. So this is the problem statement. Now we all know, now we have already discussed, this is just an illustration that how an increased total testosterone with an estriol ratio causes an increase not only in cardiovascular disease but also the entire vascular architecture. So our discussion now will predominantly be on the PCOD patients, which are common, the NCCAH varieties and the idiopathic causes. So PCOD. Now we all know that how worse are the outcomes in PCOD. The obesity, overweight, now we all know that obesity, overweight in fact is the reason why PCOD is there. It is not the other way around, which is the most concrete hypothesis till date. Now these patients automatically will have insulin resistance, hypertension and dyslipidemic profiles, and all of them are significantly higher than the general population. Now what about gestational diabetes? This was a study which showed the prevalence of gestational diabetes in the PCO phenotype. And you will find that in the baseline characteristics, more than 54% of the patients did have hirsutism features. So any hyperandrogenic levels greater than 80 nanogram per dl of testosterone at 8 am will have some amount of hirsutism. So what they showed that the prevalence of gestational diabetes in infertile women treated with ARTs with PCOD was as high as 44.4%. And in infertile women treated with ART without PCO phenotype, it was quite high. So infertility itself might be a criteria to say whether the patient will develop gestational diabetes or not. And in the spontaneous pregnancies, it was quite low. So if the study moved ahead to find out what are the probable predictors, and age in fact was a predictor, and abnormal menstrual pattern was another predictor, before the pregnancy, that was another predictor. And you might be confused, pre-gestational use of metformin. This does not say that metformin should not be used, but it points out in those patients where metformin had to be used, that means they are again pointing out to the patients who were already insulin resistant, who had already features of insulin resistant like increasing waist circumference, perhaps acanthosis nigricans, and finally on the right side you will find increased basal triglyceride level greater than 150 milligram per dl. These were the risk factors. Now what about diabetes, glucose tolerance? Again, you will find this was a study which showed that these population PCO phenotypes usually had a higher BMI, they had higher waist-hip ratio, and there was a nearly twofold increase in the rate of conversion of the subjects with PCOD with normal glucose tolerance in the baseline to abnormal impaired glucose tolerance. And the glycohemoglobin levels were continuously towards the higher level of normal in the PCO patients, indicating they had severe amount of insulin resistance, which will one day or tomorrow culminate into frank type 2 diabetes. And even if you see the insulin sensitivity index, as far as the PCO phenotype is concerned, yes, they have lower insulin sensitivity index. What about the dyslipidemic profile? Again, you will see the VLDL cholesterol, which is basically the atherosclerotic cholesterol, and the hepatic lipase, which is the synthesizer of this atherosclerotic cholesterol, are quite high in PCO phenotypes. And this shows that the black boxes indicate, the black circles indicate the PCO population, which shows they not only have a high triglyceride level, which I showed, but also this high triglyceride level ultimately culminated in the production of atherosclerotic LDL. So if you see the blood pressure, again, the systolic blood pressure in the congenital adrenal hyperplasia patients become higher at a much younger age. And what it is suggested, it is basically obesity associated systolic hypertension. So weight management program should be very important when we deal with any patients of congenital adrenal hyperplasia. So CH and CV risk, you will find that these patients have increased risk factors because of obesity, hypertension, insulin resistance, for persistent low-grade inflammation, and finally development of adverse atherosclerotic outcomes. Now what about this idiopathic hirsutism? We are confused whether these same principles apply to these patients also. These are the patients who do not have higher androgens, but what is the reason? They may have increased peripheral 5-alpha reductase activity, and that's why they are having hirsutism. In some cases, it may be familial in the family, but all the hormonal profiles are basically normal. So in these patients, it is estimated again, the PCOD, 70 to 80% of the PCOD patients have hirsutism. Now, there was also a significant risk in the unadjusted risk of developing type 2 diabetes in the idiopathic hirsutism, but risk was totally nullified when the confounders like age, physical activity, family history of type 2 diabetes, and body mass index were removed. So, the recommendations remain that routine metabolic screening is not universally recommended for all hirsute women once PCOD is excluded. Finally, we do not talk about this. A hirsute female, what is the quality of life of this female? What is the social stigma of this female? Particularly in developing countries like India, where beauty standards might lead to indignity and ridicule and isolation in these patients. Just see, this is the result. The anxiety scale, the depression scale of these patients are very high, and we all know this is beyond the scope of this lecture. We know that endogenous depression, what impact it can have in a long-standing basis to the metabolic parameters. So, our index patient, we treated this patient, and after around 1 year of therapy, we could give her a basic cosmetic reasons to be happy about. So this was a basic approach to any case of hirsutism which I was preparing during my DM days, and this is once 8 AM testosterone is high, greater than 200, you need to go for neoplastic. If it is less than 200, I will go in short, 17 OHP levels. If it is greater than 10, non-classical congenital adrenal hyperplasia is the most important. Now, if it is less, if the BMI is high, then again go for insulin resistance. If the BMI is appropriate, what should we go for? Along with hypertension, I just discussed, it is glucocorticoid resistance. And if in some cases, very rare cases, hirsutism with menstrual irregularities, with normal BMI, with mildly raised testosterone, and normally or mildly raised 17 OHP, we can go for a 2 months therapy with gonadotrophin suppression by gonadotropic superagonist like leprolide, and that becomes a gonadotrophin dependent if the gonadotrophin levels falls and serum testosterone reduced to half of the previous value. If it does not, the serum testosterone remains high, then again we have to go for a detailed MR imaging of the ovaries and the adrenals. So in a nutshell, hyperandrogenism, irrespective of cause, culminates in a dysmetabolic phenotype. Overweight and obesity are one of the primary drivers of dysmetabolic sequelae in both congenital and acquired causes of hirsutism. Lifestyle modifications and dietary restrictions have important roles in prevention of future metabolic complications in hirsutism apart from the management of specific cause. Hirsutism has a span broader than being a mere endocrinological sign to a glowing social stigma, leading at times to ridicule and isolation. So as we discuss such a sensitive topic in front of such an august gathering, let's not falter in our resolve as a human being, as a law-abiding citizen, maybe as parents also, belonging to a once upon a time most cultured, most educated, and at the same time most rebellious community, to bring justice to one who once was our very own. Welcome all the delegates to the City of Joy. Thank you.
Thank you, Dr. Chakraborty, for your excellent deliberations about the metabolic implications of Hirsutism. Now the session is open to the forum. Is there any question?
Sir. Sir.
Thank you very much, Satyam. Wonderful presentation.
Thank you, sir.
A topic very close to the gynecologist as well. And two questions. One is, if you think that it is a diagnosed case of PCOS, and as you know that a small number may not have the hyperandrogenism, or if somebody has got hyperandrogenism, will you consider the insulin sensitizers routinely? Or, because it's a very pertinent question,
Exactly.
all over the world,
Yes.
that's my first question.
Should I answer, sir?
Please.
So, very important. Sir is trying to mention about the lean PCODs who do not have hyperandrogenic features, who do not have gross features of insulin resistance also, like acanthosis nigricans. So here there are few postulates. One of them is selective insulin resistance in the Graafian follicle, which causes this anovulation, chronic. So even it is seen that even when it comes to the selective insulin resistance in the Graafian follicles, insulin sensitizers are being helpful and are recommended. So another population is, which is quite common in the Indian phenotype, is the Indian phenotype is obese by default. That is the basis of the YY paradox. We find that from the external appearance that the patient is not so obese, not so and quite slim. But if you see the fat content of these patients, if you see the distribution of the fat content, these patients are basically insulin resistant. The third group among which is the lipodystrophy group. Patients have abnormal fat accumulation in certain parts which are usually private, and we clinicians tend to miss those. And these lipodystrophic fat are the seat of insulin resistance. And again, insulin sensitizers, not only metformin, but also pioglitazone are helpful in this patient. So yes, insulin sensitizers will help these patients also, sir.
Thank you. The second one is the very difficult one, is the idiopathic hirsutism.
Exactly.
How far and what is the length and breadth of investigation you should go for when you are, before you diagnose that it's not PCOS, it's not CAH, it's not other causes of ovarian or the adrenal cause, and it is idiopathic?
So, see, sir, this is also a very important question, and it is basically idiopathic. As far the theoretical concept is concerned, it is a diagnosis of exclusion. But when we sit in our clinics and we are dealing with low socioeconomic status group, then our clinical acumen comes into play. What usually can be done is the family history. Patients who have familial hirsutism, who do not have a FG score greater than maybe 10 or 12, these patients might be excluded and followed up. Rather, these patients can be asked if they have normal menstrual patterns. These patients can be referred to a dermatologist for cosmetic care. And only again when this recur again, if at all, but after laser therapy, everything, if these recur again, then we need to move for the endocrine profiling, because they are a bit costly. So in this way, I think clinically we can go, but there is no hardcore guidelines as such.
Thank you. Thank you very
Thank you,
much.
sir. I have one question, Shotanda. I have one question. What is the risk of developing diabetes mellitus in the patient presenting with hirsutism?
So it depends upon the cause, and what we have already demonstrated, twofold increase. If along with PCOS, obesity, maybe more than twofold increase, maybe 50%, 100 times increased chance. If there is a family history, it might be more. So these are the at-risk metabolic phenotype. We need to understand this. And what is the important, where does this important lies is that because most of the PCO phenotypes go to our gynecologist colleagues. And here we need to understand that we as a team should address this dysmetabolic phenotype also. Rather, we need to understand infertility is an issue, but yes, dysmetabolic phenotype is also important, and we need to give at least a minute or two for the patient to explain them the importance of this dysmetabolic phenotype.
Thank you, Dr. Chakraborty.
Thank you, Speaker. Thank you, Chairperson. Dr. Satyam Chakraborty, please be there. It's time to facilitate our Speaker and Chairperson. I'd like to invite Dr. Sukumar Barik to please come over the stage and facilitate the Speaker and Chairperson. Dr. Sukumar Barik, sir, please.